morning. John Yue graduated with a degree in molecular and cell biology from UC Berkeley in 2009. At that time, joined the lab of Jeff Manley at UCSF to start running the TRACK TBI trials. The first TRACK trial was a 3-site trial involving UCSF, Pittsburgh, and what became UT Austin. And John worked as a CRC for that. Then started at UCSF as a medical student, remained very involved in that trial, which became a UO1, enrolling 2,700 patients from 2014 to 2018. He managed to help run the CRC Corps while a medical student. In 2018, he became a resident in the neurosurgery department at UCSF, and during his time there, he's published 300 articles.
195.
More than
195.
195?
Yeah.
Okay. 50 as first author. He's been an invited participant in significant workshops in TBI, both NIH and other major authorities. He's considered a major figure in the TBI community, and we're so glad that he came to join us today and share his knowledge.
Great. Well, thank you very much, Dr. Belton, for the kind introduction and for everyone for having me today. It gives me great honor and pleasure to be here today and talk to you guys a little bit about how we got to this point in terms of clinical research in traumatic brain injury. And excitingly, we do have a diagnostic biomarker now ready for phase 4 post-market implementation for traumatic brain injury as well. So I'll talk a little bit about how we got to this point and challenges and progress and potentials with implementation. Great. So we'll breeze through this. This is no surprise to anyone. These numbers are a little bit older now. It's probably 5.3 million people annually who get a TBI in the United States. Certainly over $80 billion of direct and indirect costs. There's a bimodal distribution, younger, probably males, adolescents in the 19 to 24 range, and then older patients from falls and untoward accidents, and especially patients on anticoagulation. Again, these numbers here on the right are from the CDC. They're a little bit older, 15 years now, but there was a spike in terms of ER visits for traumatic brain injury, and it's probably not because all of a sudden more people are getting TBIs, but the fact that the awareness for TBI has increased and more people are seeking care. So how do we better diagnose and triage traumatic brain injury patients without overwhelming the healthcare system, and also be able to help people in need and people who are symptomatic to a place where they can get further care? We'll go into that a little bit. This is not news to anyone. There's different forms of mechanisms of injury to the neurons, direct injury, coup-contra coup injury, shear injury, rotational injury, inertial injury, et cetera, all of which may cause alteration of consciousness or worse. At least in research, we've been pretty consistent in using the ACRM criteria for traumatic brain injury, which is focal neurologic deficit, or at least alteration of consciousness, but up to post-traumatic amnesia or true loss of consciousness after a suspected, or actually should be verified, traumatic insult to the head. This is not surprising to anyone either. No neuroprotectant trials have been successful. And why is that? It's because people have been using the GCS for inclusion criteria, as well as the dichotomized outcomes such as the GOSE for outcomes. And we are combining multiple injury types, multiple injury severities and comorbidities, as well as a very complicated spectrum of recovery dichotomized in the good or bad, and that usually doesn't work very well. This is a Glasgow Outcome Scale Extended. It is the most widely used outcome measure in traumatic brain injury. It goes from a scale of 1 to 8. It's a functional recovery measure, 8 being back to baseline, 7 being you have some mild issues, but you're able to go back to work, 6 meaning you're not able to go back to work to your original capacity, 5 is you're not able to work, 4 is that you can't perform your IADLs but can take care of yourself inside the house, 3 is that you cannot perform your ADLs and need someone to supervise you basically all the time, 2 is vegetative, 1 is dead. So, you know, that gamut is the entire outcome of a human being. Dichotomizing it into good or bad should really be dependent on the initial severity of injury, as well as certain, you know, comorbidities, as well as the type of injury, the location of injury, the eloquence of injury, et cetera. And a lot of trials thus far, actually most trials have not included patients based on that. And therefore, the challenge is that, you know, to determine whether a therapy or a drug works, you really need to have a well-selected patient population. So currently, everyone knows this, right? The GCS is a hallmark of TBI evaluation, but it's really probably the motor score that matters way more than the other two. This might be a little bit controversial, but in the impact and crash studies, which are the 2 largest prognostic calculators in traumatic brain injury, utilizing the initial presentation variables, the motor score consistently outperforms the other 2 in terms of predicting death and unfavorable outcome. And why is that? It's obviously because if you have a 1-point decrease in the motor score, you know, that person's definitely going to go into the ICU, probably getting a repeat scan, probably needing some sort of surgical intervention even. And that's because it's localized to the motor tracts, so, and to the brainstem. The other 2 may be less important. So if you're just saying GCS of 13 to 15, somebody with a motor score of 5 is not a mild TBI. That person, you know, needs some sort of emergent intervention. Looking at acute intracranial findings on radiologic scans, obviously lesion type, location of volume, and eloquence really matters, as well as overall global mass effect, midline shift, and herniation. So there's 2 of those things that are important in traumatic brain injury. And prognostic calculators and trial enrollment and things like that should really take all of these into account. Emerging wise, you know, is there a role for blood-based biomarkers? Is there a role for 3T MRI? I'll go into that a little bit. This is, again, different forms of traumatic brain injury can cause coma, but the treatment is very different. Epidural hematomas, you can really kind of do a craniotomy, take them out, contusion, probably medical management, maybe decompressive hemicrania for mass effect, maybe a clot evacuation, diffuse axonal injury, nothing really that you can do besides rehabilitation, subdural hematoma evacuation, subarachnoid hemorrhage, can't take it out, diffuse swelling, probably intracranial monitoring, maybe hemicrania, but probably not, and hyperosmolar therapy. So again, we can't include patients just based on GCS. It really should be based on the pathology, just like the tumor trials, just like the vascular trials in neurosurgery. So our efforts in track TBI and in data standardization traumatic brain injury really started back in 2009 when we received the grant from the Obama administration for evaluating the feasibility and utility of the common data elements for traumatic brain injury from the NIH. So these were a set of probably 2,000 variables across 4 large categories: demographic and clinical management, biomarkers, neuroimaging, and outcomes that were deemed at least important to collect by thought leaders and working groups in the field of traumatic brain injury. So this group of 2,000 variables is collated, and our task was to evaluate whether they were feasible to be implemented and whether there was utility in collecting these variables for care. So again, these are kind of the domains of just the demographic and clinical variables, which we built a database and collected them and housed. We acquired both plasma and DNA within the first 24 hours for analysis. We standardized a MRI sequence that's appropriate for trauma, standardized across different scanners. And we had a battery of outcome measures that was done at first at 3 and 6 months in the pilot phase of the study. This was our initial study back in 2013. We collected all the data that you can see there on the right. Essentially, baseline comprehensive demographic and clinical information, blood draw within 24 hours, 3T MRI within 16 days of injury, 3-month outcomes, mainly including the GOSE, 6-month outcomes, which is a full NINDS outcomes battery, and 12-month outcomes on a subset of patients. We built a data warehouse to house this. This is a subset of papers that have come out from the TRACK TBI pilot alone. So looking at imaging biomarkers, proteomic biomarkers, genetic biomarkers, clinical course, multidimensional outcomes, predictors, prediction models, and emerging analytics. So feasibility-wise, it was implementable. Utility-wise, I think we're still learning how to take better care of patients from just the pilot phase alone. So there was high utility in collecting these variables. This is our first paper that actually came out of the TRACK TBI pilot study, where we looked at mild TBI patients, again, kind of going back to my word here, with using GCS of 13 to 15, but this is what was used. And in 135 patients who had a negative head CT, 27 or 28% of them had a positive MRI. So in fact, for patients who are, who are CT negative, up to 25 to basically a quarter or a third of them may have positive imaging findings that suggest, not suggest, but that objectively categorize the fact that they had intracranial injury. And what are those injuries? Small contusions and axonal injury, as you can see there, are much better seen on MRI than CT. These are pictures that are easy to interpret for everyone in the room here, but just across the first row there on the SWI sequence in the middle, you've got some periventricular hemorrhage that's probably shear injury, and then on the FLAIR image there, you've got some inferior frontal injury that's probably a contusion that neither of which are seen on CT. And in our paper back in 2013, what we found is that subarachnoid hemorrhage on initial head CT was correlated with poor GOSE as an ordinal measure, and on MRI, contusions and axonal injury obviously correlated with poor outcome in a multivariate model. So subdural hemorrhage, contusions, and axonal shear are bad, at least for outcome. We'll take a note of that and move on. We also looked at a number of biomarkers throughout time. This is, piggybacking on work over the last 40 years, essentially. GFAP, astrocytic protein, is the most utilized protein thus far and the most promising biomarker for traumatic brain injury diagnosis. As you can see, CT positives have a much higher range on the violin plot there for GFAP. This is from our work back in 2013. It correlates with the number of head CT lesions, correlates with TBI severity. So obviously, this is a marker of central nervous system injury that leaks into the systemic circulation when there is damage to the blood-brain barrier, probably some sort of lymphatic transport, which is less understood. So it's probably a combination of those two, but mostly damage to the blood-brain barrier. We also looked at GFAP autoantibodies in chronic TBI, and not surprisingly, we have antibodies at GFAP in patients that have had prior TBI. Is there an autoimmune hypothesis? Where do those autoantibodies take the GFAP? Where do they localize? Do they generate immune system activation? I think that's a promising area for the research. We also looked at tau, which is a neurodegenerative protein back in 2017 in JAMA Neurology here. And what we found here, really just looked at figure B there, where tau correlated, with basically an AUC of 1 for chronic TBI versus controls. Is there a signal in acute TBI? There is for phosphorylated tau. How do we integrate this into a multi-marker panel? That is another area of near-term research. So where are we going from here? As Dr. Belton said, we, in 2014 and 2018, established the TRACK TBI 18-center study where we strive to enroll 3,000 patients across the US. These are the core leads of the TRACK TBI study. These are the 18 centers. We did enroll 3,000 TBI patients, which also included orthopedic controls and healthy controls. I'll go over some of the imaging and biomarker findings that we've gleaned that are important. So this is our imaging paper where we looked at 2,000 patients with GCS of 13 to 15 from TRACK TBI, as well as 2,600 patients from the Center TBI study, which is our sister study in Europe that used also the NINDS common data elements for data collection. That was done over 60 centers, including Israel. And we looked at the different lesion types that happened in GCS of 13 to 15 patients. Again, these lesions are pretty obvious to people in the room here, but the most common injury was subarachnoid hemorrhage on CT, followed by subdurals, followed by contusions. And that was seen both in center TBI and in TRACK TBI. So, okay. And looking at this cluster of lesions, contusions, subarachnoid hemorrhage, subdurals in a multivariate ordinal analysis. Well, actually not ordinal, this is a logistic regression, looking at both unfavorable outcomes. So GOSE of 1 to 4, meaning that you can't go back to work, and looking at incomplete recovery, so not back to baseline, also on the GOSE, and this is across the first year. And as you can see, contusion, subarachnoid hemorrhage, or subdural hematoma led to increased odds of both incomplete recovery and unfavorable outcome across the 4 time points. Epidural hematoma did not, intraventricular hemorrhage did not, and then we controlled for a number of demographic and clinical predictors. Age is obviously a factor, use of education is obviously a factor for recovery. There's some gender differences, baseline psychiatric history obviously matter, and prior traumatic brain injury also matters. And I think this collection of variables, in addition to the imaging variables, we should probably be collecting whether somebody has a psychiatric history in the ER to guide kind of triage and prognosis and counseling, because they do worse. These patients do worse after traumatic brain injury. A history of traumatic brain injury and lifetime traumatic brain injury should probably also be collected, because there's a second impact hypothesis, but also, I think there's a reduction of cerebral reserve with each insult to the head. Again, not surprising. And these things are easy to collect. Years of education, easy to collect in the ER. It would take you maybe 3 minutes. And with this collection of variables, we can probably better guide, and by we, I mean all physicians, ER physicians, neurology, anybody who sees a brain injury patient. These are kind of like little markers that can light up and guide us on whether they're going to have a longer protracted recovery or are at risk for poor outcomes. So going back to GFAP and UCHL1, GFAP is an astrocytic protein, UCHL1 is a neuronal protein, and this was back in 2018. Through the ALERT TBI trial, which enrolled about 2,000 patients with a GCS of, I think, 9 to 15, and found that combining GFAP and UCHL1 for predicting the absence of intracranial injuries on head CT, so head CT positivity versus negativity, there's a negative predictive value of 99.6. And this led to the FDA qualifying both of these markers together in a panel for evaluation of brain injury, again, back in 2018. So this was mostly this was actually cleared for mild TBI only, because the thought was that in moderate severe TBI, you would have a head CT and you would know that they're injured, versus the mild TBI, sometimes you don't get head CTs, and then this blood test can actually kind of guide you on whether the head CT may be positive or not. And in doing so, perhaps obviate the need for a CT if it was sufficiently low. So we also know from Esther Yu's paper back in 2013 that 27% of the patients with negative head CT have positive MRIs. So, can this marker help us in detecting positive MRIs in ways that obviously, a CT can't, because and you can't, and it's infeasible to get an MRI for traumatic brain injury in the ER or in the hospital for that matter. So we looked at whether GFAP could do this in CT negative patients as a extension study from our pilot phase. And we also looked at GFAP values compared to orthopedic controls and healthy controls. Again, this is now done on the 18-center track TBI study. And this is our work from Lancet Neurology in 2019, where we looked at the area under the curve for GFAP and detecting MRI positivity for TBI for GCS of 13 to 15 patients with a negative head CT. So everybody here had a negative head CT. And the AUC was not terrible, it's 0.78. And looking at different hour breakdowns, the 9 to 16 hour AUC was actually 0.85. So perhaps that's when GFAP peaks, but that deserves further study. And if you look at the little panel here on the right, it was actually the highest in terms of median and IQR in the diffuse axonal injury patients. So this is sensitive to something that you really can't see on CT at all. The interesting thing is that if you look at the median values for positive CT, negative CT, and then negative CT positive MRI, negative CT negative MRI, and then the controls, in CT positive patients, the median GFAP is 800 picograms per milliliter. Negative head CT about 100. Right? Negative CT positive MRI, 400. So this is already a triage tool that can be potentially used for patients, if this GFAP is a little bit higher and they have a negative CT, perhaps the counseling strategy would be, if you have symptoms, you may consider getting an MRI as an outpatient, because the values are 4 times higher in terms of the median. compared to true CT negative patients. In looking at CT negative, MR negative patients, you know, the median value is 74 picograms per milliliter. But if you look at ortho controls, the median value is 13, and healthy controls, the median value is 8. So is it picking up something objectively in terms of central nervous system damage and blood-brain barrier disruption that, you know, can't be picked up even by MRI? Maybe. You know, there's more sensitive tricography and functional MRI and things like that that can detect regional network disruptions. I haven't looked at that in correlation with blood-brain biomarkers, but there's probably a lot of potential there. So we went over that. Here's basically a chart on, you know, kind of the push to a multi-marker panel. We have neuronal injury markers such as UCHL1, which rises and falls very rapidly after injury. And by 8 hours, from some of our other studies, it's sufficiently low in which, you know, after 8 hours, it's kind of, you know, not fair to use UCHL1 as an acute TBI biomarker, which is why it's combined with GFAP, which rises and falls over hours to days. With those two markers together, then you can capture people with a hyperacute injury who present immediately after injury, potentially, and then over the first 24 hours as well. We'll go into a little bit of data on kind of subacute presentations of patients and how they correlate with markers in a little bit. There's also, you know, inflammatory markers, which are not shown there, that should be studied in terms of qualifying secondary injury and seeing if it can tamp out secondary injury. I mean, that's kind of why the original steroid trials probably was thoughtful in doing that. But, you know, including all patients and putting everybody on steroids, that's probably why it didn't work. There's apoptotic, obviously, markers. There's autoimmunity markers that rise in terms of weeks to months to years. Those are less relevant for acute TBI, but probably relevant for detection of subacute to chronic TBI. So we've already kind of went over this, you know, GFAP definitely has value not only in CT positive patients, but also in triaging CT negative MR positive patients. We also looked at how GFAP and UCHL1 relate to unfavorable outcome and mortality, since those are the two things that people seem to be interested in throughout time. In just looking at GFAP, this is our work with led by Fred Corley from the University of Michigan, 2022. Just looking at GFAP and UCHL1, the area under the curve for 6-month unfavorable outcome is 0.89 to 0.9, which is not bad. And then for mortality, it's also 0.9, right? So, you know, the big picture here is not that, oh, is this marker like really prognostic? It's really, you know, this is a marker of central nervous system injury, just like CT and MRI and other modalities, but it is not an imaging modality. It is a blood-based modality. And the more severe your injury is, of course, the poorer your outcome is going to be, but it's in relation to structure-function relationships. Not that this biomarker is a cure-all or, you know, a magical diagnostic tool. So in moving forward, this is in 2023, so about a year and a half ago, Abbott received FDA clearance for use of the Alinity blood test, which can produce a result within about 18 minutes for GFAP and UCHL1 based on plasma. So, you know, the prior TBI indicator from Banyan Biomarkers required about 3 to 4 hours to produce a result. Now it's actually more feasible to use this in acute clinical care. And, you know, Abbott is not the only company to do this. There's a number of other companies that also have assays that produce a very rapid result. So this was momentous, and we're going into some of our recent work. We looked at the diagnostic utility of GFAP beyond 12 hours after traumatic brain injury. So currently, the FDA indication for GFAP and UCHL1 is to aid in the determination of a need for a head CT in mild traumatic brain injury or concussion within 12 hours. And, you know, is there utility to expanding this? I mean, I think gestalt-wise, yes, but we had to prove it. So this was work from a couple months ago where we looked at serial GFAP values at day 1, day 3, day 5, and day 14, and how they related to the initial head CT findings. So what we found is that over time, the AUC does go down, but it's still present. So on day 5, the GFAP area under the curve for day 1 CT findings is 0.82. And even on day 14, the area under the curve is 0.74. So, should it be used alone? Well, I mean, depends on what your question is, right? If the question is, did this person present with a head injury that they suffered in the community, I don't know when, last week, there's probably some utility in using this. Is there utility in the military and to use this in the field for patients or for soldiers that have had a head injury at some point, and you don't know how bad it is and they're functional or non-functional? It can give you more information very rapidly in a way that a scanner cannot, right? Because a scanner is not mobile, and this is a blood test. So, and then going back to multifocal lesions and subarachnoid hemorrhage, we know that subarachnoid hemorrhage is the most common lesion type after traumatic brain injury. It doesn't matter. There's a lot of literature out there that says isolated traumatic subarachnoid hemorrhage doesn't need, admission, doesn't need to be followed. If they're neuro intact, you don't really need to do anything for them. There's no surgical lesion to evacuate. Do they really need any follow-up? I don't know. So we looked at this in the TRACK TBI study. We looked at everybody with isolated subarachnoid hemorrhage in GCS of 13 to 15 TBI. And what we found is that 46% of them actually had more lesions on MRI. What are they? Namely axonal injuries, subdurals, and contusions. Again, the cluster of indicators or imaging predictors that are bad for outcome. And so 46% of the isolated subarachnoid hemorrhage people, they're not isolated. They actually have multifocal lesions. And I think points for discussion potentially in the future are, should some of these people be on AEDs? Well, no, because you wouldn't put someone with isolated subarachnoid hemorrhage on AEDs, at least not in most trauma centers. But what if they have multifocal lesions? Would you do that? I don't know. So that's something worth investigating. And in looking at biomarkers, well, again, this is everybody who had isolated subarachnoid hemorrhage. So the median is going to be a little bit higher, right? But if you didn't have a CT occult lesion MRI, your median is about 200 and IQR is about 100 to 400. If you had a CT occult lesion, your median is 600 and your IQR is about 170 to 940. So there is an indicator here based on GFAP alone in which it can detect, additional injuries. And no surprise, this is a non-specific marker of central nervous system injury and burden of injury. So, we must remember that that's what it does, and it detects this, and looking at axonal injury is even higher, right? Similar to what we saw in the 2017 paper in all CT negative patients. The AUC for CT occult lesions on MRI is 0.65 for GFAP. The AUC for axonal injury is actually 0.73. Again, this is limited by kind of a small sample size here. So it deserves further validation, but there's a signal there. And why is this important? Well, if you have an additional CT occult injury, you're much less likely at 2 weeks to return back to your normal function, which is GOC of 8. And at 3 months, you've got a much higher chance of not going back to work if you have a CT occult lesion. Not surprising, right? But if you never got an MRI, you may not even know that they had an occult lesion. So is there utility here for using GFAP and UCHL1 and biomarkers, even in the outpatient setting or the subacute setting, to detect their initial injury severity and maybe counsel patients who are symptomatic on getting additional scans? And one may say, well, what are you going to do with that information? You're going to do surgery. Well, yes, you're not going to do surgery. However, you can refer them to, cognitive, behavioral, vestibular, psychiatric, anything else, right? A lot of treatment after traumatic brain injury is symptoms-based, just like treatment for PTSD is symptoms-based, treatment for anxiety is symptoms-based, right? It doesn't really matter what the source is. So there are treatments for this that you can use to alleviate patient issues and patient complaints and improve quality of life. And perhaps for a subset of patients, stop them in a cycle of potential maladaptive responses to their injury that results in further injury. We talked about all of this already. And then I think in the final couple minutes here, let's go over some of the inflammatory work that we've been doing. This is CRP. I mean, everyone knows what CRP does. It's a non-specific marker of inflammation. However, when you're inflamed, you tend to not do as well. And obviously that's also the case in traumatic brain injury, any sort of trauma. CRP is known to rise very quickly. However, it can stay in the system and continue to rise and cause a number of issues to secondary inflammation in the body and in the brain. And in even using a acute phase reactant like CRP, others include SAA and others include nonspecific interleukins such as IL-6. Looking at this, when combining GFAP and CRP at 2 weeks, the area under the curve was 0.94 for death and severe disability at 6 months. So there's nothing groundbreaking here. But the point is, you can track inflammatory markers over time. And perhaps come up with an acute TBI panel that's not just for diagnosis, but for evaluation of secondary injury and inflammation that's pathologic, that can potentially be tamponaded and potentially improve outcomes. So this is being studied, I think, even with clinical trials in the Netherlands on complement inhibitors that they're giving for severe traumatic brain injury patients. We are amidst starting drug trials, oral drug trials using anti-inflammatories for mild to moderate traumatic brain injury in the U.S. So there's a lot of potential here, and it deserves further study in well-selected patients. So where are we going from here? Coming back to data standards. Data standards are important because it allowed us to combine our data from 18 US centers and 60 European centers to not only improve replicability, but achieve statistical power to generate conclusions that actually mean something for patient care. We should validate blood-based biomarkers at time frames beyond 12 to 24 hours to expand their indications of use and aid in diagnosis claims for structural TBI. We should evaluate blood-based biomarkers across care settings and how they relate to specific lesion types and severities and their normal curves and pathologic curves over time. Inflammatory markers are important, as we discussed. 3T MRI has certainly a role in outpatient evaluation, and potentially there should be triage tools to who gets an MRI in qualifying for their disability or their symptoms after traumatic brain injury. And of course, it can yield more information, as we've seen. And advanced statistical models and prediction models should probably include time course data, should also include treatment data, because the impact and crash models currently do not include that. They're based on a snapshot in time of somebody presenting to the ER, and we know that that is not sufficient to prognosticate how they're going to do at 6 months. And of course, prevention and awareness for even mild TBI patients, which is not mild for the patients or their families. Just kind of in looking forward here, Abbott's iStat cartridge for whole blood was actually cleared as well this year by the FDA. So, it also produces results within 15 minutes. I don't know when this is going to be available here in the US. However, this is another, groundbreaking, I think, achievement in traumatic brain injury diagnostics, and not just because it's this company, but other companies are doing this as well. But it really empowers us to get blood tests and to use these blood tests. And I think to be able to use these blood tests effectively and to implement them effectively to help people and not for indications where they're not cleared for use is going to be also very important. So I'd like to thank the entire TRACK-TBI team over time, the DoD, the NIH, and other funding agencies. And thank you very much for your time and attention. Happy to take any questions.
How hard would it be to get these blood tests to rural Africa? That's military, obviously.
Right. I don't think it would be any harder than getting a blood test like a CBC to anywhere in the U.S. or anywhere in the world for that matter. Obviously the company makes these, but these are clinically cleared for use in clinical laboratories and U.S. hospitals.
Basically.
Yes.
We have that iStat machine.
The iStat, there's an iStat handheld machine that should be probably available. I don't know when it's going to be carried, I think, at least by Abbott, but it should be available, in the near term, very near term, based on the FDA clearance, and that has a lot of value in terms of point of care evaluation.
Right. The lab test itself is done in our lab here.
Correct. It can be done in any clinical lab. The plasma test, certainly. Yeah.
The whole blood test.
Right, exactly.
How do you years of education prognostics? How do you suss that out? Where's that come from?
Yeah, I think, in thinking about my mentor, Jeff Manley, has been talking about the CBIM model, which is clinical biomarkers imaging and modifiers in terms of evaluating PBI patients, and classifying them. And I think really the years of education, psychiatric history, social support, et cetera, it matters more for patients who are more mildly injured. So they don't need surgery. They're maybe hospitalized, observed for a day or two, go home. And the rest of their social predictors matter far more to their recovery than someone who is in the hospital who needs surgery, who's been, out or comatose or, medically managed for some time. So it's almost like a sliding scale. Psychiatric is probably not going to matter for severe TBI patients, but it definitely matters for the vast majority of brain injury patients who are mild. And I think, the blood-based biomarker also helps us tease out what is objective brain injury versus acute stress response, which is hard to tease out in the ER. They present similarly. People can have the same symptoms without head trauma, right? The same constellation of symptoms. So how do you tease that out? Well, I think with an objective test, just like anything else.
But stuff early hematomas, right? The results were, axonal injury. There was a definite difference between CT positive and CT negative. But stuff early was.
Yeah. So that was in patients with isolated subarachnoid hemorrhage. So everybody had isolated subarachnoid hemorrhage, and it was a small sample. However, it didn't include everybody with subdurals. Yeah, exactly. But certainly in acute subdural hematoma, we wrote a paper on this where there's an obvious correlation with injury severity. And I think, part of the question is this naphthocytic protein, so why is it elevated in extraaxial injury? Well, I think it's mostly based on brain compression. There's some expression of GFAP even in the dura and the meninges. However, with larger degrees of brain compression, you're going to have cell death and apoptotic death. This is probably why you see it.
So first of all, amazing work. I love the span over time as well as how this developed. During that period, there's been a lot of interest at the NIH in the interactions between how different severity of TBI may be also altering the clearance systems in the brain, which then may impact both immediately and then over time how these blood-based biomarkers have changed. I'm just curious in terms of your thoughts on how deficits in clearance that might occur during TBI might impact the marker in the blood, and if you'd expect a difference across severity of TBI in terms of the relationship between what's happening in the brain and the blood-based biomarker.
Yeah, absolutely. That's a great question. I think it's one that needs to be studied. We don't have a good understanding of how this thing is cleared, right? We know that it peaks over hours to maybe a couple of days and then starts going down. But what if it doesn't start going down? And that's up to the patient. They probably have evolving injury, but that's a hypothesis that needs to be tested. Patients with, AKI or renal injury, is it cleared differently? I don't know. That could be certainly studied for better qualification of how to use this, especially. So currently, the cutoff for GFAP is I think 30 or 35 picograms per milliliters. Under that, you can sufficiently rule out the need for a SCP because negative predictive value is so high. But if it's above that value, what does that mean, right? So if your biomarker indicator positive, but you're CT negative, that can create some issues. But really, it's going to be helpful to have the ER give patients kind of education materials if they're doing well and can be discharged home, to have patients kind of seek out their own follow-up care in order to not overwhelm the healthcare system. It's a little bit off topic here, but I think to the broader question of normal curves, that should be studied in more well-selected patients, probably healthier patients with more isolated lesions, and kind of see how is GFAP really cleared after different types of lesions. I don't think the sample size will need to be very high, but it's going to be very important and very informative.
It also strikes me tracking that over time might be a way to identify it because of vascular compromises. You're having some deficits in the meningeal lymphatic systems that may account for some of the more long-term effects as well.
For sure. And we, again, this needs to be published and proven, but I do think that over time, GFAP is cleared. So it's not 6 months ago or something like that. I think that, it's a non-specific marker of central nervous system, slash parenchymal, slash, intracranial injury, right? So, there's stroke literature that's shown that the AUC, after hemorrhagic stroke, is 0.74 or something like that. I'm not as familiar, but, certainly I think there is potential for not only GFAP, but a panel of biomarkers to be used to detect evolving injury in conjunction with neuroinflammatory markers to really kind of help us figure out, who is kind of on an upward trajectory or a worsening trajectory in terms of their inflammation, and is there anything selective that we can target to tamp that down.
Speaking of these panel of biomarkers, I'm wondering what else besides GFAP and CRP anybody has looked at in this group. I'm thinking of other like epigenomic targets or transcriptomic targets, things that you might be able to integrate into a bigger panel that might be even better at analysis.
Yeah, for sure. I mean, that's an evolving field. I think we're just kind of scratching the surface of these proteomic biomarkers. S100B has been used in Scandinavia to help detect TET-CTs for the last, at least 10 years. We've shown that kind of it's not as good probably compared to GFAP and UCHL1 combined together, but there's probably a role in using S100B as part of the panel. Neuron-specific amylase has been used. Neurofilament light has been used where kind of decreases in neurofilament light suggest worse injury and less neurologic recovery. So that can be used at 2 weeks and beyond. More types of, kind of emerging biomarkers. I think neuroinflammatory biomarkers, IL-6, IL-8, IL-10, IL-17 in terms of the, neuroprotectant or the, not the anti-inflammatory cytokines. I think 17 is there, IL-2 is there. So, whatever you would expect from the pro-inflammatory, anti-inflammatory cascade, I think we've looked at that, and there's signatures with certainly outcome after brain injury. Not surprisingly, I think if you have ulcerative colitis in general, your outcome is probably better or worse than if you didn't have ulcerative colitis. If you have gout, you probably have worse outcome at baseline than if you didn't have gout. So, chronic inflammation is a thing. IL-15, I think, has a more neurospecific origin. So that's been shown to have an effect on, and then of course, serum amyloid A, CRP, and TNF-alpha and certain others as well. So there's a panel there that is probably a priority neuroinflammatory panel that can be tracked over time, and we're working on publishing those results. And in terms of RNA, I think that's just untested realm, and a lot of hypotheses have been generated, not a lot of targets because it's not well understood. And I think it's a ways away from clinical implementation, but nevertheless, in the 10 to 20 year span, I think that's going to be very important to look at kind of like moment by moment changes and responses to therapy.
We appreciate this. So much more to be done, and it's going to start with carefully looking at many people.
Great. Thank you very much for your time.